Please. Hello everyone, good morning. And I'll be discussing basics of how do you work up when you're looking at a phakic IOL patient. So a this is a star ICL on the tip of a fingertip, and when you show this to your patient, it is very convincing and satisfying for the patient to actually see what is the size of this beautiful lens. And then this is another image which I use to counsel my patients: where would the lens be going inside the eye? So it goes behind the iris and in front of the natural lens. So all these pictures help patient understand how the technology is working and how the technology is addressing the myopic power of the patient. And then this nomogram has been pasted in my OPD, and it takes away 50% of my counseling time. This is a nomogram that works in 90% of the patients and help the patient understand very clearly that which option would suit him the best. So we say that till the time your specs power is or refraction is between -1 to -8, the procedure of choice is usually a laser based refractive surgery. And in our hospital, our preference is usually LASIK or Contura, which is topo guided LASIK in eligible candidates. And then when the number goes beyond that, when you have powers between -8 and -18, then the preferred choice would be a star Evo ICL. And it is very comfortable for the patient to accept it, provided that the star Evo ICL is US FDA approved. And then when we go powers even beyond that, like already discussed, when your power is between -18 up to -25, then you have a choice of biotech or care phakic IOLs, in which care phakic IOL is a thinner IOL, can be used in very high powers, but even biotech works equally well. And then when you have hyperopic patients between +1 to +4, usually the recommendation is a laser based refractive surgery. And the moment you go beyond that, you can also go ahead with the ICL or RLE procedures. The machines today allow corrections up to +6 for hyperopes, but it is preferred that you keep it up to 4 and not go beyond that because of unnecessary symptoms that appear after that. Now, in ICL workup, this is the most important step when you're evaluating your patient for an phakic IOL or an ICL surgery. There are some mandatory things that you have to check, probably double check, which are refraction, and the refraction has to be a proper dilated refraction. Then you need wide to wide for your ICL sizing, and then you need an adequate anterior chamber depth so that the ICL is cleared from the crystalline lens and the endothelium. Then, of course, other checkups in which your retina checkup is the most important, because usually ICLs are being implanted into people who have high myopic powers, and in high powers, we often suspect lattices, holes, or weakening in the retina. And if you ignore them, sometimes your patient can land up in a retinal detachment. So, it is very important to do a thorough retinal examination. Endothelial cell count, again important, axial length, keratometry, and dry eye status. So this slide just helps you to do a mental calculation when your ICL has been ordered. So you can just calculate in your mind that suppose the power is between -1 to -18, the correction would be somewhere from 0.75 to -18, and so on. And the rough idea, when you have an ICL in your hand and you're about to implant it, you can have a basic rough calculation in your mind that ICL power is approximately 1 diopter more than the spectacle power. So suppose a patient that you're operating has a power of -9 diopters, you should have approximately a -10, a 10 diopter ICL in your hand. And when you when you're doing your mental calculations and just analyzing if the ICL has been ordered correctly, because you don't want to land up into surprises and an ICL exchange. So how does the calculation work? So basically, the minus cylinder is transposed to the plus for cylinder calculations. So suppose a person has a power of minus 12 with minus 6 at 90. Now you have to transpose this power, and the ICL that would be ordered would be minus 18 with plus 6 at 180. So of course you don't have to worry too much about it. You have softwares to help you do these calculations. But let's say suppose you have a patient of higher power and you are planning to implant an star ICL. Then let's say suppose the patient comes to you with minus 16 with minus 6 at 90. So then this power would not be accepted as minus 22 with plus 6 because that is beyond the correction. So it will be accepted as minus 18 with plus 6 at 180. Now, when you are sizing your ICL, it is very important that the appropriate wide to wide distance is taken correctly. And usually, this is how we follow the size of ICL. And when you are sizing the ICL, just for a rough calculation in your mind, you should remember that the ICL size is approximately 1 millimeter more than the wide to wide. And how do you measure white to white? So of course you have different instrumentations. You can do it with a digital caliper, which is highly reliable. Then you can do it with an optical biometer, something like a lens star. Also you can do it with a pentacam, but vernier calipers should be avoided. And usually the confusion is that what is white to white, what is black to black, what is gray to gray. So when we are sizing ICL, we are looking at white to white and not gray to gray and black to black. So I've marked here. So you should, when you're taking the measurements, you should have an idea of what exactly are you measuring. And usually digital caliper works wonderfully, but then it is also important to verify that if your measurement is accurate or not. So do the measurements with a digital caliper, then do it with a pentacam, and the pentacam reading should be approximately 0.2 millimeter higher. And then do it with an optical biometer like a lens star, and the reading should be about 0.5 millimeter more than the manual calculation. So suppose when you're sizing your ICL and you get measurements like the digital caliper is giving you 11.8, the pentacam is giving you 11.9, and the lens star is giving you 12.3. That means your calculations are bang on. Now, sometimes you would have these confusions in your clinical practice that let's say the measured value was 11.6. So you see here that at 11.6, the size is 12.6. And the moment the white to white becomes 11.7, the size changes to 13.2. Now, this is where the confusion lies, that which ICL to actually implant, which size to choose. Should we go ahead with the 12.6 or should we go ahead with the 13.2? So the first thing you can do is, of course, talk to the star people. They will help you. But again, you can do a gonioscopy and you need to see the angles. Suppose the angles are open, they are wide open, you can go ahead with the higher size. And if your anterior chamber depth is good, it is more than 3 millimeters, like somewhere around 3.3, 3.4, again, you can choose a higher size. But the minimum anterior chamber depth that you need to implant a phakic IOL is 2.8 millimeters. Below this, it is better to avoid it. And what are the ideal tools for measuring ACD? So, of course, pentacam, highly reliable. But of course, you can get it done with an A scan also. But sometimes you have to be very careful that from which point are you measuring the ACD. You have to remember that this measurement has to be from the endothelium and not the epithelium. And of course, you have optical biometers and OCT to further refine your measurements and accuracy. Thank you so much.
Thank you, Dr. Rahil. I'll ask you a couple of questions and the audience are free to ask for questions. In the meantime, I'll ask Dr. Sarika to be ready with the next talk. Any questions for Dr. Rahil before I ask Dr. Rahil some questions? Arun, I'm on the dais. I'll talk to you later. Right.
If the ACL says 2.75 or 2.7,
So usually for beginners, we are recommending that at least 2.8 should be the depth. But somebody who in the experienced hands, we are also pushing it down to 2.75 in our centers, but not below that. Below 2.75 is an absolute no. Sir, but still again below 2.75 is kind of risky and better avoided. No, in 2.78 we can just put the lens like that. Doesn't become a problem.
Actually, till 2.7, now we are putting the lens. Of course, this is 2.8 is the recommended guidelines. So you are taking your own risk when you're putting 2.7 without any fears. But it is not officially allowed to put 2.7, right? Because nobody will come to your help if something is not going right. But between 2.8, our cutoff is 2.7, though of course we like to keep it above 2.8. What we do is we have a lens star, we have a pentacam, and we have what is called an anterion now. The anterion is taking images on the visual axis, not the optical axis. And so its ACD readings are about 0.2 more than the lens star. So that 2.7 is covered by the anterion, which was not getting covered officially on paper by the lens star or the pentacam.
But also, I would like to add that in myopic correction, sir, we are not making PIs in any patient now. So all the newer lenses have that centra hole, and it works perfectly well. Even in when we are implanting it in a 2.7 or let's say 2.75, we are not making any additional PIs.
So same question, when the white to white, the lens diameter changes after certain time, like 11.7 or 11.65. What will you prefer, a bigger lens or a smaller diameter?
No, sir, it actually depends. Suppose you have a controversy between 11.6 and 11.7. Then it is very important that you do a gonioscopy and see the angles. And suppose the angles are open and you have a good ACD, then it is preferred that you go ahead with a higher sized ICL. But suppose you don't have enough ACD in hand, or suppose the angles are not very widely open, then it is preferred that we go ahead with a smaller size.
Actually, I will just answer that again. If you have a spherical lens, go for one side slower. Because even if it moves a bit, it's not a problem. If it is a toric lens, up for a size higher because you need it to fix tightly to the sides. Assuming that other parameters are within acceptable limits. Okay, now you're asking one question.
Sorry, come again, sir.
A different type of optical biomarker. Suppose the lens star and IOL masses.
Sir, I am used to working only on the lens star. I think you
No,
have
but
any, you have
there is no
you have
difference
IOL
at all.
marks. So
Like I told you, in all optical biometers, there is no difference at all. The readings match perfectly to 0.01 or 0.02. They are so accurate, all of them. But there's only one biometer which is giving a difference of 0.2 only in the interior chamber depth readings. That's it. That is the anterior one. Otherwise, all biometers are very precise. That's the marvel of technology.
So I think you are using all the three lens star IOLs, Master 700 and the Interion
And the anterior, yeah.
to do the white to white, but all the readings are exactly the same.
Yeah, exactly the same.
You prefer the diameter or the manual micrometer? Which will give you the most confirmed
So,
See,
so
the
the
manual-
caliper, the
sorry.
digital caliper.
I would put it the other way around. The automatic system is more dependable because the system is in the hand of your optometrist. Manual white to white, you could be measuring 4.5 or you could be measuring 4.6. You would never know. You can never be that precise. right? Your hand is moving, it is stable, it's a different perception. The optical is going through the translucent area and is getting blocked by the transparent area at the limbus. So, but the optical one can have errors because of pigmentations or opacities at the limbus. So the manual is double checking those errors that you're not making a gross error there. So the manual is a must. But when you take a glance and your manuals are matching up with your optical, you are comfortable that you don't have to go and check. It's already there.